Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. The show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is interventional pain management. And with me in the studio is Dr. Zack from the Deuk Spine Institute. My institute.
That's right.
Yep.
Thanks for having me here, Joe.
You're quite welcome, Dr. Chambers. Pain management is something that I think has become more popular in the last 5 to 10 years. We didn't publicize this before, did we? I mean, isn't this really interventional pain management, a reason type thing?
Sure, absolutely. You know, interventional pain management really started the impetus in probably the late 60s with Dr. Bonica, an anesthesiologist. It's slowly been growing since then, but definitely in the last 5 to 10 years, people have been paying a lot more attention to that. And unfortunately, some of the negative press that comes along with what pain physicians do, you know, here in Florida, there's a real issue with narcotics, prescription drug abuse, and people unfortunately taking too much, giving it to their friends. Some people take them and sell them. So Florida has really, I think, tightened down the leash on pain management physicians, primary care physicians about how they're actually treating pain. And so as an interventional pain management physician, I'm very worried about my patients. I care about my patients. I don't want any harm to come to them. And so we have a wide variety of things that we can do that don't require the narcotics to allow patients to get pain relief and really get back into their lives.
Yeah, and I've not asked this question from many of the doctors I've had on any of our shows. You mentioned pills, but in your type of work, you don't prescribe any pills for pain management, do you?
On a very limited basis. You know, if you have a chronic pain condition that's non-cancerous, we're not talking about, you know, the cancer pain.
Okay,
it's a different animal.
That's a different part.
You know, patients here in Brevard County have low back pain, hip pain, knee pain, neck pain. All these different things can be treated without using narcotics. Now, when patients come in and they're hurting really bad, they can't sleep, they can't enjoy life, they're just wake up and they're in pain all day. We can give them different types of medications to bridge the gap until we actually treat their pain and bring down that pain level.
What kind of thing could you use for that?
Well, there's all sorts of different kinds of medications that are used for a variety of other things, such as antidepressants. Some of our medications that work for antidepressants are fantastic for pain control, but we use them in smaller doses. So there's some things that...
Okay, let's talk about the drug Cymbalta.
Yes.
For people who have a condition such as fibromyalgia, Cymbalta, which is an antidepressant, is also used to help treat fibromyalgia because it affects the nerve endings. Right.
It affects basically the problem. You know, the FDA has only 3 medications that help with fibromyalgia. Cymbalta is one of them, Lyrica is the next, and then one of the newest drugs is Savella. So when a patient comes to me and their chief complaint is fibromyalgia, you know, I ache all over the place, I have tender points, I can't rest, I'm going to be using one of those 3 medications and see what works for that patient.
How about Neurontin?
Neurontin is a good medication. It's not specifically designated by the FDA for fibromyalgia, but it's something we use all the time for a radicular pain or the numbing, tingling, pins and needles that are going down your legs. It's a great drug for that.
Folks, this is interesting because I warned Dr. Chambers before we started the show. I'm the person, and you know you've heard me talk about it on TV before. I have fibromyalgia. I have lower back pain. I think I have some pinched nerves. I know I have stenosis. So all the things that Dr. Chambers and I are talking about, you know, I have firsthand knowledge of it. And I know the importance, Dr. Chambers, for the average lay person to understand more and know more about interventions that they can go to a doctor and use to effectively treat some of these conditions. But I have had other doctors, as Dr. Sheldon, for instance, who really, he wants to get to the root cause of a problem. And when we talk about interventional pain management, we can treat the symptoms of the pain, but sometimes there are conditions we'd have to go and find the root cause of the pain and fix that.
Yes, absolutely.
Let's talk about what you're here for, interventional pain management. We have people that you have problems you can't operate on for.
Right.
You have things that you have to do, interventional pain management. And then that's what I would like for you to tell our viewers what pain management does, how we do it, and we'll get into the subject of some of the facet problems, the uses of the different things. But let's just go with general pain management.
Absolutely. The reason that I went into pain management is because I want to help people. I think most people became physicians because they want to help people, treat them, and get them back into life. When I was a medical student at the University of South Alabama in Mobile, I did a rotation with a burn surgeon, Arnie Luderman. Amazing person, just fantastic. And one day, he sat us all down around a table, and he asked us a question. He said, "What is the job of a physician?" And we all gave our answers, and he said, "Well, that's good, but that's not the real answer." And he said, "To be a physician, your real job is to relieve suffering." And that really, it stuck with me. Absolutely, it just hit me. I'm like, yeah, I want to relieve suffering. And I know that there's so many people, especially our seniors of Brevard County, that are hurting. They've been hurting for years and years, some decades. They come into my office. I've been hurting for 20 years. And I've been taking these pills for 20 years, and they're just not helping. And it just breaks my heart to say, you've been suffering this long. Because that's what it is. They're suffering. At some point, people just can't handle the emotional issues that go along with their pain. They just quit. And so they start to suffer, and their family suffers, and their quality of life goes down. And
the quality of life is an important 3 words.
Absolutely. I mean, we can't forget about our seniors. We need to allow them to live their lives too. They want to pick up their granddaughter. They want to go play baseball with their grandson. They want to do these things. So, that's really where I'm coming from in terms of why I came into pain management, why I'm doing what I'm doing. And I want each of our seniors to know that there's hope. You don't just have to take the pills. We're going to talk about the interventions, but we can treat your pain so that you don't have to be stuck on these pills and that you can actually get back into life.
Would it be fair to say that most of the pain, of course, you can treat arthritis in the wrist, you can treat, you can use, lidocaine or...
Sure, numbing medications,
you can use
steroids.
Temporary type things that give relief, and some people they give longer relief. But generally speaking, the type of work that you do affects movement of the arms and the legs and the back. Can you describe for our viewers the things that you can do to help people with? And is the most serious pain the lower back pain, or not?
Yeah, typically. I wouldn't say that's the most serious, but it's the most common.
Okay.
If you have neck pain, that's the most serious to you.
It hurts too. I noticed that.
So absolutely, lower back pain is extremely common across the United States. At any one point, there can be 20 to 30% of the population that has low back pain. Now, if that turns into a chronic condition, that's when we start to get worried. Pain in itself is a natural protector for us. If I put my finger over a fire, my brain tells me, that hurts, pull it away.
Right.
That protects me from hurting myself. But when that becomes a chronic problem, it's not helping me. If my back hurts every day for 6 months or a year, that's not helping me, stay away from danger. And so ultimately, what we want to do is have people come in, and we're going to evaluate them. I'm going to do a physical exam. I'm going to look at, their MRI and the x-rays. I'm going to listen to the patient. I think that's so important. You know, every time somebody comes into my office, they say, well, my primary care physician, they're just not listening to me. I go into their office, they can only spend 5 minutes with me because they're so busy. And so they don't listen to me, they're not hearing my story, and they don't know exactly what I'm saying. And so I try to take the time. As physicians, we're all busy. We're absolutely busy. Yeah. You know, and that's a whole different topic. But I really try to listen to the patient because they know their body much better than I do. And when they tell me it hurts right here when I bend over, that gives me a fantastic view of, you know, what is causing the pain and helps me narrow down so we can find the actual cause of the pain.
What do you do to determine the cause of the pain? And then once you determine the cause of the pain, let's maybe stick with a lower back problem.
Sure.
What are the treatments you offer from the least invasive up to the most invasive?
Okay.
Okay.
Great. So low back pain. There's a lot of different tissues, bones, discs in the back that can all be causing similar pains. So what I do is I bring the patient in, and the three main things I consider is the patient's personal story, what they've done, if there's been any injuries, if this has been a gradual oncoming, you know, basically just listening to the patient's story. Second of all, I look at the images, the MRIs, the x-rays. And then lastly, I do a physical exam. The most important things, I think, are listening to the patient and the physical exam. If you, myself, and 5 other people in a room all had MRIs of our lower back, half of us would have bulging discs, but maybe 1 or 2 of us would actually be having pain from those discs. I have patients come in all the time and say, well, I have 3 bulging discs, that's where my pain is coming from. I say, well, maybe, maybe not, because they don't always cause pain.
That's a good point.
Yeah, absolutely. So in the spine, it could be a disc pain, it could be a tendon pain, a muscle pain, or it could be a joint pain. Those are typically the main players when it comes to back pain.
You said muscle?
Muscle, joint, disc, and tendon.
You said tendon.
Tendon,
okay.
yeah, because you do have some muscles in there that attach to the bone. So
okay, all right.
So after I've listened to the patient, I've looked at the MRIs, I do my physical exam. And there's a whole variety of tests I can do to help narrow it down, to help me know, yeah, it's most likely the disc, or it's most likely something called a facet joint, which is where the joints come together in the back. So at that point, once I've made up my mind and say, this is the most likely thing that's causing your pain, then we can proceed to do injections or anything else that might be more invasive. Now, the second part of your question was, what do you do? Starting from the ground up,
yes.
You know, the least invasive thing that we can do would be medications and physical therapy.
Okay.
Most people need physical therapy. As we advance in age and we have pain, what happens? We protect ourselves. We don't do the things that we normally do. And so, unfortunately, our muscles get weak and they, you know, atrophy. They get smaller. They don't work as well. So one of the main things we need to do is get you to the physical therapist, rehab those muscles, get stronger, strengthen up your core, allow you to actually move your body. So that's huge. Secondly is the medications. Sometimes, if it's necessary, we can do short-term narcotic medications, but rarely. Not all the time do we need to do that. And then we have the other medications that I described earlier that we can use to attack the pain really from many different directions. But what we don't want to do is add on so many medications. A lot of our seniors, they're on 5, 10, 15. I've seen people on 30 medications. And to me, that seems a little...
It's a lot.
A lot.
It is a lot, Doctor.
And your whole schedule revolves around taking your pills all day long. So I don't want to just add a whole slew of medications. I may add 1, or I may add 2, but I'm not going to make any drastic changes. Because we want to see what that medication does by itself. If we need to switch to a different medication or add a different medication on, we can do that. Sometimes this takes time, but anything worth doing, you know, you want to do it correctly.
I agree.
So that's the bottom level. After that, we can get into injections. You mentioned lidocaine, which is a numbing medication, something you might get from the dentist when they're numbing up, you know, for a tooth extraction or work, and also steroids. These medications help decrease the inflammation that's happening around the joints or the discs They shrink down that inflammation, allow the nerves to do their job properly without being impinged upon. A lot of the times, this will relieve pain dramatically for patients. They come back a week later and just, thank you, because they didn't know that option was available. If something like an injection doesn't work, then we can consider something that's more invasive. Some patients might need a spinal cord stimulator, which we put into the epidural space. It's just a space near your spine. And what it does is it sends out electrical stimulations to your spine and ultimately confuses the signal. If I were to have knee pain or hip pain, that signal travels up the nerves into the spinal cord and ultimately to my brain. And my brain says, oh, I'm hurting. So the spinal cord stimulator sits there and it sends those electrical stimulations to that message directly in the spinal cord, and it confuses it. So instead of your brain feeling pain, it feels something like a vibration. And so patients are able to deal with that pretty well. It's an amazing technology. And if we need to get to that point, we get to that point. If none of the things that I do work, sometimes the disease is just that bad to where an injection, a steroid, isn't going to fix it enough to where a patient can get back into life. So that's the ultimate goal. Get out of pain, get back into life. Then we can think about referring you to, Dr. Deuk works with us. He's a fantastic neurosurgeon. And he would evaluate the patient and say, well, these things have failed. You've done physical therapy. We've done the medications. We've done injections. Maybe we need to take it to the next level. And then he'll decide if you're an appropriate candidate for back surgery. I think something that's terrible, that happens a lot. I'm sure you've met many, many people who've had back surgery and it failed. It didn't work. Their pain is just as bad as it was before. Unfortunately, sometimes people get back surgery for the wrong reasons. I was talking to a patient just the other day, and she was absolutely convinced that she needed back surgery. And she hadn't done the injections. She hadn't done the medicine. But she's already scheduled for a back surgery. And I tried to educate her and say, this might be a terrible mistake. I wouldn't do that. But she was so set because the doctor had looked at the MRI, said, oh, you have bulging discs. We need to fix those discs and do a fixation on you. Is that going to cure her pain? I don't know. It's a gray area because she hasn't done the things necessary to prove where that pain is coming from. So we don't want people to get unnecessary back surgery. And that's one of the reasons I joined the Deuk Spine Institute, because we're all on the same page. Dr. Deuk, as a surgeon, doesn't want to do back surgery unless it's the appropriate patient.
I had him on a show. We did a show on stenosis and sciatica. And he very clearly said that, if I remember correctly, he said at least 6 months in pain before he even attempt surgery. And he said he would not go just on an MRI alone. He would take results of an MRI, a CT scan, and x-rays, and examination, and history. And he said the same thing. Did you talk to him before you came to the show?
Well, like I said, we're on the same page. I think
you are on the same page.
The same philosophy of caring for patients.
But let's. I want to make sure.
Sure.
I want you to talk about some of the treatments for facet pain. We only have 10 minutes, so let's talk about facet pain. What exactly is? Where is the facet? What is the facet pain? How is that related? Is that related to stenosis at all?
Well, the facets. In our spine, we have our spinal cord, which is a huge bundle of nerves that gives us sensation, muscular power all through our body. Goes up ultimately to the brain to help our body work. Now, what happens is that it's encased protectively within the vertebral spine. All those bones in your back, you can feel them as you feel your back, all the spinous processes that are coming off of those bones. Between each of those bones is a disc, which gives us some stability. But on the side of these bones where they come together is a true joint, much like a shoulder joint or a knee joint. Where it comes together, there's a little bit of fluid there. But it acts as a stabilizer to help protect you as you're bending forward, bending back, turning to the side. It's all about the facet. So when you have arthritis in the facet or inflammation in the facet, you're going to hurt. You bend over, and it takes you 3 minutes just to stand up because it hurts so bad.
I know.
And I'm sorry.
No.
But people live with this pain. And so the facet joint is an amazing stabilizer. It protects. But when it hurts, it's going to hurt you all day long. Just about anything you do, you're going to feel it. Patients come to me and they're like, well, I really wanted to go on that outing with my husband or my wife, but I paid for it the next week. Oh, I paid for it so bad. It hurts so much. And patients know that. They know where their limits are. But sometimes they're like, I'm just going to do it anyway. And then they pay for it. So these facets, we can treat that. Absolutely. What we do, the ultimate treatment, is what's called a rhizotomy, or a radiofrequency ablation. It's basically a burning of the nerve. That sounds scary, but it isn't. I'll explain. So that's the treatment. But we have to find out that the facet joint is actually what's causing your pain. I wouldn't want to just go in there and start burning a whole bunch of things on a guess. So what we do is we bring the patient in on a procedure day. We have them lie down on a table and we use an x-ray so that we know exactly where our needle is going. But I numb up the patient and I direct that needle to the nerve that supplies the pain to that joint.
How can you tell us the nerve is supplying the pain? How do you do that?
Well, the nerve is called the medial branch nerve, and it comes directly off of your nerve root at that specific level. Every facet has a nerve that supplies pain there.
Okay, you can see the nerve that goes to that section of the facet?
On X-ray, you can't physically see the nerve. You could see it on something like an MRI, but we know where they travel. All through anatomy and all that, they've done a million different studies to show where that nerve runs, and we know the exact spot. So I drive my needle directly to that spot where that nerve is going to be sitting. It's a very specific place, and it's held down by a tendon, so we can find it every single time. I go there with my needle, and then I put in some numbing medication. That's it. No steroid, no narcotics, just numbing medication. Within 15 minutes, that numbing medication is going to work. It is going to numb up that nerve, without a doubt. I come and I see you. If I had done it to you, I'd come out 15 minutes later. Say, Joe, how are you feeling? I'd stand you up. I'd do another physical exam. I'd have you bend and rotate and twist and do everything that normally causes you pain. And then you would give me an answer. You would say, no, that block didn't help. Or, this is fantastic. I can move again.
What if it didn't work?
Well, if it didn't work, then most likely the pain is coming from somewhere else. That's what's called a diagnostic test. It gives me information. It either says the pain is coming from there or the pain isn't. If the pain is coming from there, that's fantastic, because then I can actually go in there and treat the pain by burning the nerve. Most people get anywhere from 6 months to 12 months of pain relief by that burning of the nerve.
How do you isolate stenosis pain from facet pain? How can you do that? Or can you?
Sure. Well, the back is a tricky place.
Oh, I know. That's why we're talking about
Exactly. Most people that come into my clinic have more than one pain. They have disc pain. They have facet pain. They might have hip pain as well. And all of these things are very similar when it comes to symptomatology, where you're feeling your pain, where it goes. So I have to listen very closely to what you're saying. Sometimes it's a great picture. Sometimes it's going to take a little investigation to get through it, to find out what really is causing the pain. Sometimes it's one thing, sometimes it's two or three. But the point is, we can treat it, and we will eventually get there. I want people to have hope. I don't want them to have despair. People who've been in pain for years and years, they despair. They wake up not wanting to get up. I want to take that away, give them their hope back, and ultimately help them out.
But in dealing with the back, there are still many unknowns.
Yes.
There are a lot of unknowns. Let's say that you you do the rhizotomies, the epidural, you do the shots in the big muscle that go into the hip joint, and nothing takes the pain away. Then at that point, I think the person becomes a candidate for possible surgery. Where can they do something to the facet joint through surgery to correct this problem or not? Sure.
Well, if you have stenosis, you mentioned stenosis, where the nerves come out the side of that bone. And it's just like you said, it's a canal. So the nerve's jumping through a canal. If there's stenosis or squeezing of that area, that, of course, is going to cause the pain. Yes, we can do what's called a foraminotomy. It's what the surgeon would do. It's not something I would do. But they go in there and they're able to basically chip away that area, enlarging it, so that the nerve can breathe again and work properly.
So in the whole, at the Deuk Spine Institute, you have interventional pain management, you have Dr. Deuk as a surgeon, you have therapy, you have all these interventions, and it's so like a progressive thing. If this, you try this, and then ultimately you may have to have surgery. Yeah.
And if you end up having to have surgery, then that's the right choice. But we want to make sure that our seniors are not getting unnecessary back surgery. Because, you know what happens if it's unnecessary, they're just going to come back with the same pain. And then we're just going to have to start from the beginning anyway. So we try to keep them from having surgery if that's at all possible and treat it with the less invasive means. It's so much easier to put a needle in and out of the skin than actually cutting, putting in rods, and fixating your spine. That's a huge surgery, and you can never take it back.
I know that I've had the interventional pain management on my back, and the ones set of shots they did 10 on one side and 10 on the other. And I was awake for the whole thing. Mm-hmm. And Dr. Patel.
Yes.
And he asked me how I was doing. I said, I'm not going anyplace until you finish the other side.
That's right.
But my point here is that you don't put people out. In interventional pain management, for the most part, people are awake so that you, as the doctor, can see if what you're doing is effective.
Yeah, absolutely. With most of these people, they can handle the injections without anything. Some people, we give them a little bit of relaxant, sedative medication to help them through that. Some people can't handle it at all. They need some anesthesia, and that's okay. We take them to the hospital. We give them a little bit of anesthesia so that they can get through the procedure safely and get the treatment they need. But it's all individual. Mainly, I'm an anesthesiologist. That's my main training.
I know that.
So I am all about patient safety. I love my patients. I want to get them through everything that I do safely. I don't want to cause harm, ever, to my patients. And so, that's always on my mind. Keep the patient safe, do what's best for them, and try to ultimately get them back into life, get them out of pain.
And I think you'll do that. And I want to thank you, Doctor, for coming here today. There's a lot more we can discuss, and we'll do another segment. We'll talk some more about it.
Fantastic.
But thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL 1300 AM at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. Thank you for watching today, and please tell others about our shows so that more people get information on how to develop their own aging and care plans. Thank you, Doc.
Thank you, Joe.